surfactant was introduced, the odds of death in the hospital for very low birth weight infants were reduced by 30%. Now, clinicians can choose to administer Surfactant while ventilation continues. Surfactant gives you greater choice to meet patient needs. This program will review surfactant function and explain the options for Surfactant administration. Normally, endogenous pulmonary surfactant lowers alveolar surface tension. This stabilizes the alveoli and prevents their collapse. Infants with RDS are deficient in pulmonary surfactant. For them, Surfactant replenishes surfactant and restores normal surface activity.
Surfactant's safety and effectiveness have been repeatedly documented in controlled clinical trials, a treatment IND, and numerous other studies. Since their introduction, surfactants have become crucial in treating neonatal RDS, and Surfactant is the surfactant most frequently chosen in the U.S.
Each dose of Surfactant is 100 milligrams phospholipids per kilogram birth weight, given in fractional doses. To administer Surfactant, several options are available. Choose an endotracheal device and treatment strategy to form a dosing plan for each patient. In initial trials, Surfactant was given by interrupting ventilation. Now, by using a neonatal suction adapter, or valve, Surfactant can be administered while ventilation continues. With a single lumen endotracheal tube, Surfactant is administered through a shortened 5 French catheter. When inserted into the ET tube, the distal end of the cup catheter lies just above the carina. With a neonatal suction adapter, a shortened 5 French catheter is also used. The cup tube must be left long enough to pass through the adapter and ET tube and still have its end lie just above the carina. A complete dose of Surfactant is equally divided into 4 fractional doses. Correspondingly, the infant is then treated in 4 positions so that Surfactant can more easily reach all areas of the lungs. Surfactant may be given immediately after birth for prevention or after a diagnosis of RDS is confirmed as rescue. For either initial strategy, up to 3 subsequent doses may be given for retreatment at 6-hour intervals. For prevention of RDS, Surfactant is given to premature infants of less than 1,250 grams birth weight, or those with evidence of surfactant deficiency. Stabilize, weigh, intubate, and dose infants as soon as possible after birth, preferably within 15 minutes. Manual ventilation is often used in the delivery room. For rescue, confirm RDS by X-ray and treat infants as soon as possible, preferably by 8 hours of age. If respiratory distress continues, additional Surfactant may be given. In either strategy, up to 3 subsequent doses may be given within the first 48 hours. Give additional Surfactant no sooner than 6 hours after the preceding dose. Retreatment should occur only if the infant has RDS, remains intubated, and requires at least 30% inspired oxygen to maintain a PaO2 less than or equal to 80 torr. These are the different dosing options for administering Surfactant. In practice, the choice of dosing plan is the clinician's. In this program, you'll see one infant treated using a single lumen ET tube in the prevention strategy. A second infant will be treated using a neonatal suction adapter in the rescue strategy. A third will be dosed using a neonatal suction adapter in retreatment. In clinical use, any combination of endotracheal device and treatment strategy is acceptable. Each vial of Surfactant contains 200 milligrams of phospholipids in an 8 milliliter suspension. Refrigerate the drug in its carton and inspect it before use. Surfactant should appear off-white to light brown. Swirl the vial gently. Do not shake it. Avoid foaming the suspension. Allow the drug to warm to room temperature before use. Hold the vial in the hand for about 8 minutes, or let it stand at room temperature for at least 20 minutes. Do not use artificial warmth. From the options available, this infant will be treated with a single lumen tube in the prevention strategy. This begins with a review of maternal records before delivery.
They've just finished the ultrasound, and the ultrasound is consistent with the dates, 6 weeks.
Candidates are infants at risk for RDS, typically those expected to weigh less than 1,250 grams. Larger infants with prenatal evidence of surfactant deficiency may also be treated. In the delivery room, have ready a syringe and 20-gauge or larger needle, 2 endotracheal tubes, a 5 French end-hole feeding catheter and a sterilized cutting tool, and a room temperature vial of Surfactant. Start dosing as soon as possible after birth. Suction the oropharynx and place an endotracheal tube. Note the tube length. Confirm the tube placement by auscultation. Use a duplicate endotracheal tube and cut a 5 French end-hole catheter to match the length noted. Next, weigh the infant. The specific dose of Surfactant is based on the infant's birth weight. Using a septic technique, draw Surfactant into the syringe. Attach the modified catheter. Expel the excess through the catheter, priming it, and leaving the full dosage in the syringe. The clinician will give the drug in 4 fractional doses, each with the infant in 1 of 4 positions. The specific sequence is not important, as long as all 4 positions are used. Once the infant is stabilized, incline the head and 1 shoulder down 5 to 10 degrees. Stop ventilation. Insert the cup catheter fully into the endotracheal tube. Deliver the first fractional dose over approximately 2 to 3 seconds. Gravity will help distribute the liquid. Manually ventilate for 30 seconds. The bag should be capable of delivering 100% oxygen. Ventilate to prevent cyanosis and to provide adequate air exchange and chest wall excursion. Next, rotate the infant on the cephalocaudal axis so that the head and upper shoulder are slightly down. Deliver the second fractional dose over approximately 2 to 3 seconds. Manually ventilate for 30 seconds. Now, position the head and 1 shoulder slightly up. Deliver the third fractional dose and ventilate. Finally, rotate the infant on the cephalocaudal axis so that the head and opposite shoulder are slightly up. Deliver the 4th fractional dose and without flushing it, remove the adapted catheter. Again, manually ventilate for 30 seconds.
In controlled clinical trials with infants between 600 and 1,250 grams, prevention dosing with Surfactant reduced the incidence of RDS by up to 70%. Deaths due to RDS were reduced up to 87%. Prevention dosing with Surfactant poses no significant risk, and it helps prevent the occurrence of RDS.
For this infant, the clinician has chosen to give Surfactant through a neonatal suction adapter in the rescue strategy. With a suction valve, ventilator support will not be disrupted during dosing. Infants with confirmed respiratory distress syndrome may be treated using the rescue strategy. RDS should be confirmed by X-ray and be severe enough to require assisted ventilation. Infants should be treated as soon as possible after being placed on a ventilator. Adjust ventilator settings during the procedure. For dosing through a neonatal suction adapter, prepare a syringe, a duplicate endotracheal tube, a 5 French end-hole feeding catheter, a sterile cutting tool, and a vial of Surfactant warm to room temperature. Cut the catheter to match the combined length of the endotracheal tube and adapter. Dosage is again based on birth weight. It is not necessary to re-weigh the infant. Fill the syringe with Surfactant. Attach the modified catheter and prime it. Leave only the full dosage in the syringe. Some clinicians use the bed to position infants. As in the prevention strategy, gently incline the infant with the head and one shoulder up. With the ventilator in place, insert the modified catheter fully into the suction adapter valve. Deliver the first fractional dose. Hold the cut end of the catheter back to the adapter. Mechanically ventilate for 30 seconds to distribute the drug. As shown for prevention, reposition the infant and repeat the process for each of the 3 remaining fractional doses. After the final fractional dose has been given, remove the catheter without flushing. Regardless of the dosing options used, certain observation and monitoring procedures should be followed. Marked improvements in oxygenation may occur within minutes of the administration of Surfactant, so stay with all infants after dosing. To avoid hyperoxia, frequent and careful clinical observation and monitoring of systemic oxygenation are essential. Adjust the inspired oxygen to maintain an adequate PaO2 or transcutaneous PO2. Closely monitor oxygen status, airway pressure, and respiratory rate. When compliance or oxygenation improves, or if cyanosis or bradycardia occurs, adjust the ventilator appropriately. Do not suction the endotracheal tube for 1 hour following treatment, unless occlusion is suspected. Continue to ventilate as needed.
In controlled clinical trials, rescue dosing with Surfactant reduced deaths due to RDS by up to 68%.
This infant will again be treated through a neonatal suction adapter. Retreatment with Surfactant is virtually identical to initial dosing procedures. For all infants, however, ventilator settings may differ slightly. At least 6 hours is required between treatments. Before retreating, warm the drug to room temperature. Suction and stabilize the infant before dosing. Increase FiO2 sufficiently to prevent cyanosis. Set a rate of at least 30 per minute with an inspiratory time of less than or equal to 1 second. Settings may be adjusted to ensure adequate oxygenation and ventilation. Use a syringe and needle to draw up the dose of Surfactant. Continue to base dosage on the infant's birth weight. Do not re-weigh the infant. As before, administer Surfactant in fractional doses over approximately 2 to 3 seconds. Ventilate for 30 seconds after each fractional dose. Remain with the patient until stable, changing ventilator settings as compliance improves, or if acute deterioration occurs. Surfactant can now be administered in several different ways. A dosing plan includes the clinician's choice of an endotracheal device and a treatment strategy. Since its introduction, Surfactant has become a crucial drug in neonatal care. Well over 100,000 infants have been treated. Surfactant is the preferred survivor.